Welcome to the VCU School of Medicine's Minutes of Time, Teaching in Medical Education podcast series. This series is produced by Faculty Development in the Office of Faculty Affairs and features discussions with innovative medical educators about best practices in teaching, learning, and scholarship. If you know a preclinical or clinical faculty member that is making a significant impact on student learning or research, let us know by leaving us feedback on our website at go.vcu.edu/iteach. We'd love to share their story.
Welcome. Today we are talking to Dr. Cheryl Al-Mateen. She is the Psychiatry Clerkship Director. Cheryl Al-Mateen has been instrumental in the development of VCU School of Medicine's new curriculum, particularly in her work on health disparities, cultural competency, and introduction to trauma for the patient, physician, and society, or PPS longitudinal curricula. Dr. Al-Mateen has a wealth of experience in the clinical setting, both as a practitioner and as an educator. Dr. Al-Mateen, can you take a few moments to share with us a little about yourself and the Psychiatry Clerkship?
Sure. I have been working at VCU since 1989 when I finished my own training, and this is really the only job I've ever had.
Wow.
VCU has had a lot of different things for me to do over time, and so I've been practicing child and adolescent psychiatry that entire time, but in different settings at the state hospital, in community mental health, in an outlying private clinic that we had some years ago, and then on the inpatient day treatment and residential units at Virginia Treatment Center for Children. Currently, I work on the inpatient unit as well as serving as interim medical director there. As far as teaching, I have served as an attending for M3 students on their clerkship. I have been clerkship director since 2004, and then I worked a great deal with the physician, patient, and society longitudinal curriculum from the very beginning.
It's great. Cases are essential to what you teach, but tell us more about case-based learning and how you got started with it.
Sure. One of the things that was really important for the PPS curriculum is incorporating cases because medical students want to think about the practical applications of everything that we're teaching them. So I learned that I need to really incorporate cases even for students in their very first semester before they'd even seen a patient. As I spent more time doing that, it became really clear that, particularly as a clinician, that's just the best way to teach. We're so used to clinical teaching where we have students or residents or fellows and we're working up a patient with them and asking them questions about it. That's what comes naturally to most of us who are clinical educators, to simply talk about a patient and help the student, help whatever level of learner it is, understand the layers of the patient in that way.
So what role does CBL play in the physician, patient, and society longitudinal curriculum?
We actually incorporate cases into pretty much everything that we're teaching. We use cases as examples to the material that we're teaching, and then we ask the students to discuss different aspects of the cases to use the material that they've just been taught.
So I'm sure most of the cases you use are engaging. But is there one case that really sparks the medical student's curiosity or elicits an energized response?
Yes. In physician, patient, and society, we have one session where we're covering a combination of things. What we do in PPS is in the first semester, we give a lot of basic principles in a lot of different areas. And then what we begin to do is integrate these areas. We have one session where it's spirituality and cultural competency that are together. We have a case of a young lady who was admitted to the hospital after having been sexually abused by her stepfather, and she was pregnant by him. And she was very clear that she would kill herself if she were not allowed to abort this baby. Her mother was supportive of this. She was very late in her pregnancy to be getting the abortion. And so she was admitted to the psychiatry unit for this purpose, for the suicidality. And having the students discuss it is extremely energizing for them because they find all the different layers to the case and talk about her rights, the rights of the clinicians who may not want to help her get an abortion, the patient's rights to be able to have it, and they're able to integrate ethical principles and many of the things that they've been working on during the course of the year.
Tell us about some challenges and constraints to using this method. With the case it is that you just shared, it can get a little touchy for folks to discuss.
Yes, but part of PPS is talking about the things that are touchy and that are difficult because it's far easier in one way to think of the technical aspects of medicine and the things that there are evidence for, and that those are the things that you do or you don't do because there's evidence or there's not evidence. The aspects that we talk about in PPS are those things that are not always as readily measured. Those are the things where the art of medicine really comes into play.
Thinking about the art of medicine and then integrating cases, what steps should a novice case educator take to effectively facilitate a teaching and learning experience?
To really think about cases that impacted them as physicians or healthcare providers, if they're psychologists or other clinicians. To think about all of the things that actually happened at the time that the case came through, because whatever happened with those seasoned clinicians will really impact what's happening for the learners, and those will be cases that the learners can really tap into.
Do you write your cases yourself, or do you find them on shared scholarly resources like MedEd Portal?
Typically, I write my cases. There are people that I have seen, or I'll ask someone that I work with about a case. I have a hard time making up a case. So generally, there's some nidus of an actual patient that's involved. For the cases that we use in psychiatry, we have a team of folks that have worked on the cases, and individuals will use parts of patients that they've seen, and we may sit down in the committee and add aspects to the case that we feel are relevant teaching points for the clerkship.
It seems like CBL is a good opportunity to have learners think about and discuss some difficult subjects, especially when you're writing the cases yourself. You're using your experience.
Yes.
So how have students reacted to this method? And what do you think makes case-based learning so beneficial for them as learners and also future practitioners?
I think there are several different ways to use cases in learning, and I think the learners really like it because it makes them feel like physicians, because they're using clinical information to make a difference for a patient or to figure out how they'll manage a patient like this moving forward. It also helps them bind all of the different concepts together, and I think that really helps them stick. Personally, when I read, it's most effective when I have a patient to connect that reading to, and so I think that's something that we can generalize to all of our learners. Students really seem to like the cases, and if they don't have a case, then they're saying that whatever it is that's being talked about is not relevant because they can't figure out how it would relate to a patient unless you can show how it can relate to a patient.
And so you've used CBL a lot. For new faculty who want to be an expert case facilitator, what tips do you have for them?
I would say think primarily about your own clinical learning and how you learned on the wards with your patients. Then figure out how the basic science or the very early learning blocks of medicine apply to any of those cases. Then help the student see that part. The hardest thing, I think, is that initial leap. Many of us who trained a long time ago feel that in the first year or two, at least the first semester, there's not a need for cases because we need to learn the building blocks. I think we really need to get past that and realize that it's all clinical because that's how the learners see it, and that is the way to connect with them. So if you think of that as the only way that they're really going to be able to hear you, and that you know how to do clinical teaching because that's how you've learned ever since you've been a third-year medical student, it will flow.
We've heard you share some great information about CBL and what it can do. Before we go, can you share with us a story that inspires you to continue to use case-based learning?
Sure. In the psychiatry clerkship, we switched a year ago from having didactic sessions on didactic days to only using case-based learning. We want the students to unpack the case, not in a problem-based learning way, but we tell them these are the things that you're going to need to present about this particular case. The students have the same roughly 6 cases that they have to present each rotation, right? So rotation 1 has 6 cases, rotation 2 has 6 cases. When I look at one particular case, the way that the students come to present it is so different based on the group of students. So one set of students will come in and they'll draw things on the board, and that makes perfect sense. Another set of students took off with the idea of Harry Potter and how to use this clinical information through all of the Harry Potter movies, and they made slides, and they did a really excellent job of taking information from the Harry Potter universe and relating it to this set of information that related to psychiatry. They were energized, I was energized, and it was fascinating. The other thing that happens is that faculty members who otherwise are not that interested in working with M3 students because they feel like they would have to say the same didactic over and over again, they're happy to come in and have students present a case to them and to just ask them questions like they do on the ward. And it's just so refreshing for them. The idea of taking cases, and sometimes I take them from television characters and then add some things in from patients that I've known or from things that are in the literature that I should be able to see. All of it is inspiring to be able to come up with cases that have a lot of depth so that the students can find more to do with them.
Dr. AlMateen, thanks so much for sharing with us today about your experiences and the use of case-based learning in psychiatry and medical education.
You're very welcome.